I'm going to talk about today is trauma, what it is, how memory works, and how trauma memories work that are different to other memories. The ripple effect that trauma can create not only for that individual, but also the people around them and the systems around them, and the different responses that people have to trauma as well, and also what we can do as healthcare professionals and MDT colleagues to support those clients as well. So what is trauma? Trauma is a psychological response that any of us have when we experience either ourselves or we witness a distressing event. And there's some key defining features to trauma. It's where it's been a really overwhelming event, not just something that's stressful, but much more beyond stressful. It's also where, crucially, we feel like we've lost control, that we have had no control in that situation or very little control in that situation to do anything, either to change the outcome of it or to do something while we're experiencing it. And that we have at the core of that a profound sense of helplessness. And if you think about, just hold as I'm talking, those two feelings around control and helplessness, because those are often the defining features of what we see in rehab as well, and how we try and support clients as best we can to have some or as much control as possible, and also to manage those feelings of helplessness. What I would also say is, what I might experience as trauma, you may not, and the next person. So the term in the eye of the beholder is never more true than with trauma. It is very much a subjective experience, and it's a subjective experience because of some of the things that I'll talk about in a little bit, why we might be predisposed to experiencing an event as traumatic, and what might lead some of us to feeling or being more vulnerable to trauma than others. So how memory is processed during a traumatic event. Memory and trauma, it's not processed the way it is. So we're here, it's Thursday, it's sunny in Manchester. It's nearly, for those who have kids, half term. So those are all things that help us have a narrative to pin us to us all being here together at the conference today. So that helps us have a timestamp of it's Thursday, the season, and this is how it is. So when we recall it, say next week, we're recalling it in a sequence of events and a narrative around that memory. The difference with trauma memories is we don't process it in that same way. So we process it almost, I describe it to people, it's like a funnel whereby we're bombarded by lots of information at any one time, and we have to sift out some of that information, and a large part of that information we don't process. However, in trauma memory, in a very, very quick time, we are bombarded by a huge amount of information and experience, and so we process that on a sensory basis. So what we hear, what we smell, what we see, what we touch and taste. And so whenever we process it like that, when you often then will say to clients, or they start to recall what's happened, they either have huge gaps in their memory or they have inherited memory. And what I mean by that is they will have memory that they have learnt after the event, either from witnesses, from family members, from other people that may not have been directly involved, and that might become part of their memory. So what happens is there's 3 areas in the brain that are disrupted in trauma processing and how we encode those memories. So the prefrontal cortex, the front part of the brain, the amygdala and the hippocampus. And why those are important, which I'll come on to talk about in a little bit, is how we process them as men and women are different. So that's why you will have different ways that men might bring information to their rehab process, and females, it'll be different experience for them. But also we know that that hippocampal and amygdala, they become really, really overactive when they're experiencing a traumatic event, and that really heightens that sensory and emotional processing of that trauma. But also when it comes to either sharing information, retelling it, or indeed the processing of it, what happens is the stress hormones then will impact on the retrieval and also how they recall that memory. So I'm fascinated by trauma because it's the one thing that actually in all of the memory stuff is really, really different compared to how we are day to day. So it's a complete passion of mine. I know that's a bit odd to say, but it means that when it comes to supporting clients, actually what I see is everybody's experience. There is no truer sense of everyone's experience being totally different. And although, of course, you've different treatments, how you implement those treatments to clients is very much individual. But there are some similarities, which I'll talk about as well. So the ripple effect of trauma. So you have the incident itself, which, as I say, that will have a direct impact on the individual, but also witnesses as well. And certainly what I see, not only in my treatment work, but also when doing assessments in the expert witness space, is some people may not feel necessarily traumatized by the actual incident. And when you really unpick that with them, what happens is when you get that timeline for an individual on what their experience has been collectively, is so going back to how we process information on the memory. So if you think about you're already in a really, really heightened state, and you then might experience something else after it, like being in ICU. So for example, there's one client in particular that I'm working with, and what she has shared with me is the incident itself, she has very little memory of. So that doesn't feel for her like the source of the trauma. But actually what some of her memories are that are more traumatizing for her are when she was in ICU. And when she was in ICU, heavily sedated, didn't know where she was, didn't know what was happening, but also in that altered state is processing information really, really different. So if you are already in that heightened stress response, you're not orientated, so you don't know where you are, you don't know who you are potentially, then that's going to mean you're experiencing things under heavy sedation that is going to potentially be traumatic for you as well. And then for some other people, that it's not just one-off surgeries. You know, even Molly's story of for some of the clients that we work with having multiple surgeries. And again, what I would say is it's sometimes what the source of trauma for our clients is how they're treated by the healthcare professionals when they're in those situations. It sounds like nothing, but it's actually massive, where if you're not kind and compassionate, it potentially traumatizes people. And we all know that those amazing healthcare workers that most of us started our life in the NHS in, no one turns up to work to cause harm. However, in being burnt out and being overloaded and being overstretched, often what happens is that detachment that they have from the patient, and so they then will respond in ways without seeing that patient as an individual, and that can really solidify or compound some of that trauma that they've experienced either from the ICU or from the incident itself. can we not record the next bit in the sense of the litigation process? I'm afraid to say I've had the privilege over the years of working with some amazing legal teams. And I think Irwin Mitchell is right up there, where clients are truly at the centre of the case. However, it's still really hard for clients. And certainly what I see, and I'm not going to put any clients on the spot by asking them this, but certainly what I see is having to wait, feeling like they have to prove themselves, having to show how they need something. And it is such an intrusive process. If I was in that situation, I would be the worst client ever, because I would be so resistant, because I'm a really private person. And so in that, when you are going through that process, already haven't experienced the incident, your period in hospital, your rehab may not have even started, that intrusiveness and asking people to re-experience and retell their account of the incident can be re-traumatising or compound aspects of the trauma. There's lots of ways, which I'm going to talk about, on how to mitigate that or certainly minimise the impact of that. But I think there is something around how we actively and collectively as an MDT do things to proactively make the process a lot more trauma-informed. And also rehabilitation. What I didn't say in how we process trauma. So you have the cognitive aspect of it, so the encoding of the memory and how the memory is stored. Most people's trauma happens to their bodies. And often what I think the litigation process does, in order for someone to engage in that process, they often detach from their head and their body, as I call it. And so certainly the first part of treatment, psychological treatment, is almost reconnecting with your head and your body on what it feels in your body. That sounds a really simple process to do, but if you as an individual don't like the body that you are now currently in, and you're really resistant to that, you can experience a lot of resistance psychologically to that reconnection. And also there's a somatic process. So what I do is a lot of joint work with physio colleagues and OT colleagues on, we hold a lot of trauma in our body. And so although you may not have a conscious memory of it, as an individual who has experienced a life-changing event, you might move a part of your body, or your body might feel a certain way, and that might feel very similar to how it was at the time of the accident, but you've no conscious memory, and you're having a really big response to that. So there's something around how you not only treat the cognitive element of it, but also how you treat the somatic, so the body. And that's a long journey for people. So often what we talk about is the process of adjustment. And again, like trauma, the process of adjustment is so subjective, and it can be the lifetime of that individual or not, and everywhere in between. What I would also say is some of the things here on the left around survival, identity, relations, those things that are massively impacted. It's not the individual, and I think as Molly mentioned there in her case, it's not just the individual who is impacted by it, it's often the family members massively affected. And while they want to be supportive and loving and caring, the accident has also happened to them as well. And when it's happened to them, certainly in the West, in our society, we have a very clear expectation on what we should do. You should be dutiful, you should be loyal, you should be caring. You should not be upset by it. You should not be depressed. It should not be impacting on you more than it is the person who has had the accident. And so when that is a very laboured narrative that a lot of family members hold, it means that often by the time we get to family members and really try and support them, they've been holding on to so much in order to try and do their best. And I think certainly putting in early interventions for families is a critical part of the rehabilitation process, because sometimes they need it way before and are open to it way before the individual who's experienced it. Also, that leads me to relationships as well, not only marital relationships. You no longer will be the people that you once were. That's the reality of the situation through no choice of your own. And so you both will understandably have two different processes happening. And change, for those of us in long-term relationships, we change over time, don't we? And you hope that your partner will come along on those changes with you. However, when those changes happen massively overnight and you feel like you should be grateful that your loved one survived, that feels really, really difficult and often a burden that can happen for couples. And it's supporting them really to navigate not only what has happened and the potential trauma for both of them, but also that wider impact on the people that they are now. And for some couples, the grief of the life that they once had and the loss of the life that they had planned in the future. And also work. These sound really obvious. And it's when I was doing the presentation, I was writing work and identity, and I thought, it's so easy to just write them, but for this, sometimes it takes years and years. So I didn't want to undermine or dilute the massive impact of just writing words on a screen have for the people that we support. I'm a mum, I'm a wife, I'm a twin, I'm a psychologist. And if you took all of those roles and identities away from me tomorrow, good luck. Because I would be kicking, screaming, I'd be the worst client ever because I would be so resistant. I would want to hold on to those with everything that I have. And so when our loss of identity or change in identity is impacted by an incident, an event, what happens is we feel often lost because all of our roles and our identities and who we are make up Jan or make up Richard or Ruby. They make up who we are. And so when those are removed for us or diluted in some way, that has such a catastrophic impact. And so really trying to support people to hang on to their identity. And that's why you'll often hear people talk about, the client's really resistant, or I'm like, good. They should be resistant. I know it's a headache on some level, but that is a totally natural process and it's not time limited. They might be resistant for years. They might be resistant in all the time that you're working with them. However, that's on us. That's on us to get really, really creative in thinking, right, how do we engage this person in a way that works for them, not in a model or an approach that I think should work for them. And I think that's where finding the right fit between client and an MDT is so, so essential. Because for those people, it's all of those hopes, dreams and aspirations that are no more. I need to keep an eye on the time. I'll be talking here forever. Okay, so then just on the back of that, we can have something, so there's different types of trauma, and you can either have the primary incident, and that's where the trauma lies. But often and you will all see it as well, is you get an accumulation of trauma responses. So remember how trauma is processed. So you're already in that really heightened state of survival, which means then that the things that happen after that might, as individual incidents, might be stressful in itself but not cause trauma, now are either traumatic in themselves and compound that initial trauma. And so you get this an accumulative effect. And I think that's where MDTs, we can really help a lot in minimising the impact of that, because what we end up seeing then is a lot of those maladaptive coping strategies that clients might engage in order to survive. So the different responses to trauma, so that will, so some people will be predisposed to experiencing some aspects of trauma, so they might have experienced things in their childhood that may mean that they're more vulnerable or more predisposed to experiencing an event as traumatic. Or it might be personality types, so some personality types are more predisposed. But also, and what Molly was saying there around support systems, that's where in those really, really early days that can really mitigate the scale or the accumulation or the impact of trauma. So men have a much higher impact or likelihood of externalizing aspects of their trauma. And again, this is shaped in the society that we live, so we expect that men are going to be much more angry or have those more heightened responses, and that they will not be connected as much to their emotions, so are more likely to suppress their emotions. And part of that is because of the prefrontal cortex, because that's highly active, and what that does is that takes them into a more logical state, so into a more state where they're thinking practically, how can we overcome this, what can we do? And again, because that front part of their brain is activated or more highly activated, they're more likely to engage in some of those risk-taking behaviours and maladaptive coping strategies. And so therefore we might see a more delayed onset of PTSD symptoms because of the suppression. Whereas women are more likely to internalise their symptoms, but also women are, how they process the trauma is different. I'm not going to ask you to do a show of hands because we're recorded and it might be used. What I would say is, if you're in a relationship, male-female relationship, have you ever been having a disagreement with your partner and the female has said, well, and a year ago you did this? And you're like, did I? Well, as women, what we are super amazing at doing is, if there is heightened emotion, we process that on a much deeper level than men. And what that means is we have this amazing ability to recall what happened a year ago in a way that our male partners may not be. And so they might have been going, well, I was maybe washing the car at the time that you were doing that, because their frontal lobes were more engaged. So, but what it also means is, because of this internalizing process, is women are much, much more likely to dissociate. So what that means is they're more likely to be flooded with the emotion and feel more disconnected, like they're not in reality. So that might be if you're talking to a female client and there's almost like a glaze over them when you're talking about key aspects of the accident. That's maybe a good sort of note for you to think, are you actually here and now? And why that's important is How we process information is we need to be present. We can't be a pendulum where we are thinking about the past or worried or anxious about the future. And so in doing that, if you're dissociated, then you're not present, and it leaves you more vulnerable then to experiencing some of the trauma symptoms. Really easy way to do it is just speaking a little bit louder and getting them to feel their bum on the seat, feet on the floor, and orientate them to the room. But also, while women are able to have this greater recall of detail of their PTSD or the incident that happened, they're much, much more likely to ruminate on them. And they're more vulnerable to experiencing complex PTSD, which is a different part of the diagnosis. So behaviours, fight, flight, freeze, fawn. Those are the 4 responses that we have to experiencing. And so fight, usually this is where we will see more males in this place. So the fight where they're more reactive, have increased irritability, more likely to have what we call irritable depression, so low in mood but really irritable with it. Flight, so that increased anxiety, panic. And then freeze is, I think what's really instrumental in the freeze state is that feeling of shame, where people feel really shameful either about part of what has happened or how they might have behaved shortly after the incident. And then fawn, and that's where people are feeling really overwhelmed, or they feel like they have to please others in a way to connect. So minimising the impact of trauma, and this is for us as an MDT and legal teams. So triggers, we are going to trigger our clients. That's a given. Just by the very nature of the work that we do, just by the very nature of them coming to see us. And so in that, it's thinking about, you will not know lots of the triggers that might be. It might be a perfume you wear, it might be a way that you sit, a way that you move, but also the client will not know always what their triggers are. They might know what the most obvious things are, but a good way to help clients start to think about their triggers is, in absence of the obvious ones, is to ask, what kind of things do you avoid now that you didn't avoid before? And so that might be a way to start to help them think about it. So we all have a window of tolerance, and our clients are no different. So the window of tolerance, so the optimal window where we want to get everybody into, is here. And what will happen after trauma is that window of tolerance will become much, much less. So it will mean, and I think this is massive for family as well, so things that may not necessarily have bothered that person beforehand, they will now really, really have a big reaction after it. And so what you see is somebody will have a big response. They'll have lots of adrenaline, lots of cortisol, but then they come down quite a bit. And when they come down quite a bit, because we've got a biofeedback system from our body to our brain, so we've increased heart rate, increased cortisol, blood pressure. When that then starts to come down, our body's then thinking, are we in survival mode here? Are we alive? And so what it does, it then will actively crave sugar, carbohydrates. Unfortunately, ladies, we're more prone to this after a trauma because we are more sensitive to this cycle of adrenaline up and down. So our words matter, and this is trying to, even if it's one thing that you can do today, which is thinking about how you might change some of the phrases that you do to be more trauma sensitive. Why that matters is in the work that we do with clients, we are not talking to the front part of their brain. They're more conscious states. Our words are talking to their subconscious or the amygdala, that fear center. where we consistently can say to them, you're safe. That's essentially what we're doing. We are hardwired as individuals for predictability. And so if you've went out on an ordinary day to do something really ordinary that you've done hundreds of times and it's resulted in a life-changing experience, you have fundamentally learned that life isn't predictable. And so when you've learned that, your brain is more sensitive then to going into overdrive when things either don't go according to plan or it's not predictable. And that's when you see people say, oh, he's so controlling now, or she really just has to have everything in order. For me, that's your brain and your psychological response trying to put predictability in when you fundamentally learned that the world is unpredictable. But we can be predictable for our clients, so we can start to tend to that part of their brain to say, you're safe. You coming to see me is safe, which is why anybody who's ever come to see me, no matter where we move our offices to, is always the same. Sarah's laughing because we've moved recently. And it's always the same, because what you're trying to do is you're trying to create that predictability every single time, not consciously for the client, but in that subconscious way to say, you're safe. You're safe when you come here, and you know every single time things are going to be okay. Like the way Richard started by saying there's going to be no fire drills. So what he's priming us for is things are okay, and if they're not, we're going to be alerted. So we're primed for it as well. So these are ways, either as a solicitor or case manager, physio or an OT, you might look at this and think, geez, I'd never have said that anyway. And that's fine. But these are just going to give you some ideas on how you might do it. So how to do more trauma-informed assessments, conversations. So prepare the environment and do some pre-planning as well, building that safe and trust. It doesn't have to be done all at once. As Ruby's saying, doing the more empowerment, collaboration. There's lots and lots of different ways that you can do trauma-informed interview techniques when you're trying to get information from people, and also observing the client, like sorry, I didn't get your name, but what you were saying around how you respond to each individual client. It has to be that way. So trauma isn't just the accident or the incident or the event itself. It's throughout that whole person's journey. It's not just them itself, it's their family, the rehab process, and the impact that has on their identity and their relationships and their work. It's also being aware that male and females will respond differently to trauma, and how we really increase those support systems very, very early on in order to minimise the escalation of trauma symptoms. We as an MDT can do massive things, not just in our treatment, but in our interactions, from if you go and you meet a patient or a client right through to delivering that treatment, and recognising that we are going to trigger them in some way, but working in that much more collaborative and empowering way in order to minimise the impact of that. So what we're going to do now is I have the privilege of talking to Ruby. I'm going to talk to Ruby, ask some questions about her recovery. However, remember, we're doing it in a trauma-informed way, so I'm not getting into detail about the incident or the details of what has happened. So I'll just give you a little bit of an overview for those of you that don't know Ruby. So in August 2021, Ruby was involved in an accident when she was out with her baby Leon, and she experienced severe orthopedic injuries, resulting in her right knee needing to be amputated and wearing an external fixator on her leg for over a year. Ruby's journey is incredible, as is many of our clients, and she's been supported through the major trauma unit at Atri, and she's had intensive rehab. all of that is amazing, but we all know that clients only recover and engage in that rehab largely based on the people that they are. And so I hope you'll all give me a warm welcome to welcome Ruby. How are you feeling?
All right.
Yeah.
I'm hot.
It's nerve-wracking getting up here, no?
Yeah, I'm not much of a speaker at all. I'm hot.
Ruby, thanks so much for talking. I know we've talked about some things that we might focus on based on the presentation that I've just done around trauma. I'm not going to ask you about trauma, but maybe as a starting question, what would be helpful to know is your experience of psychology and that process for you.
So my psychology started when I was in the major trauma unit. From the day I can remember, really, psychology was involved. And then I was transferred straight from hospital to STEPS, where I started psychological therapy. And then I came home, had about a 4-month break, and I still see my psychologist now.
Perfect.
Yeah, I've done a bit of EDMR and exposure therapy.
Yeah, it means nothing.
Yeah,
really but it's worked on some level for you.
Yeah, the accident itself I've processed.
Yeah.
And I go back to where the accident happened, and mentally I'm over that. It's now moving on to acceptance.
For sure. And I think, that process of acceptance, like we talked about it, it's such an individual process, isn't it?
Yeah.
And often denial is a key feature of that. There's that nice graph that you start with anger, you go to denial, but it's individual, you'll be all around it. And so I'm curious to know what your process of adjustment has been, particularly around
I think
denial.
with denial, that's something I'm still working on now. Like, for example, when I picture myself in the future, I'm picturing myself with 2 legs.
Yes.
Even still to this day. So when I have to take a step back and think of reality and how the rest of my life is actually going to be.
Yeah, and I think it is that part of it is a lifelong journey in adjustment, isn't it? Ruby, tell me the most proudest thing you have done or been involved in as part of your recovery.
So my goals is always to be able and independent, and I'm at home as a single mum with my little boy, and I can do it all. I don't need anyone's help. I've got good support, friends and family, obviously, but just the fact that I can crack on with life with Leon and just,
And I think that part of identity, you're a nurse as well, aren't you?
Yeah.
That you've kept that quiet, she's a nurse as well. And the identity for you as a mum was so important, wasn't it?
Yeah. So my relationship with Leon, really, that I just felt like he'd been ripped away from me when I was in hospital. But then as soon as I got into rehab, I just stepped back into that mum mode. And then I just look at the positives, really, and see how much Leon developed from being in rehab, being around so many people all the time. He had such good communication and vocabulary from such a young age. And and he's so confident now. I wish he wasn't as confident sometimes.
It's tricky parenting, but it's a nice skill that you want your child to have.
Yeah, so it's like impacted them positively, really, than negatively. I can't really... Yeah.
In what way, Ruby, do you feel you've changed as a person?
I'm a lot stronger, I think. I was never into fitness before, and now I'm doing CrossFit 4 times a week.
Wow.
Who I was before, I don't know. I'm just working, I suppose. My goal is to get back to work.
As a nurse?
I think your job's a big part of your identity. And I worked hard to become a nurse. So, I want to get back.
Brilliant. And what do you think you've learnt about yourself during your recovery?
I'm determined, that's for sure.
You certainly are determined.
Motivated. I've just taken any therapy that's been offered. I've just give it a go, and
Great.
Yeah.
I know, Ruby, that you support lots of other people who have experienced life-changing injuries. And I wonder what advice you would give to somebody that might be starting out quite early in their journey of this.
How you are now isn't going to be how you are 1, 2, 3 years down the line.
Yeah.
Take any support that is offered. Try any therapy, even if you think it's not for you. Just give it a go. Get psychology involved straight away, because I've met so many people and they don't get rehab or psychological support till further down in the line, and I think that's quite traumatic for them as well.
So when I was talking in the presentation about the ripple impact of trauma, and it was the accident, the hospital, and then the litigation process, I wonder what advice you may give to our legal colleagues in how best they can support clients during...
Get involved, because Irwin Mitchell got involved with me when I was in a hospital bed, and I think that I really, really benefited from that. But it was day one that got me in touch with Irwin Mitchell, and then Irwin Mitchell got me in touch with Steps, and everything was just from the hospital bed to now. Everyone who's been involved. Just get rehab straight away, I suppose.
And what about in terms of support? So emotional support, yes, you've got psychologists, but of course that's only going to be like once or twice a week max, isn't it? So how do you think the network that you had around you really supported you and your recovery?
Friends and family. Yeah. And then when I was in Steps rehab, the support that my family got there as well, I think that was, helped a lot. Sorry, I'm losing where I'm going
It's
now.
okay. It's okay. Thank you so much, Ruby, for talking to us. Thanks.